I'll be speaking in brief regarding retinopathy of prematurity. ROP is a vasoproliferative disorder of the retina, which is uniquely seen only in premature infants. ROP is one of the major emerging causes of preventable childhood blindness because of improved levels of neonatal care, as the survival rate of low birth weight babies is increasing day by day. ROP problem has become so huge that World Health Organization has identified ROP as a priority area, particularly in middle-income countries and in urban areas of Asia. It has been seen that the number of infants blind from ROP in India will soon be equal to the rest of the world put together. There could have been three distinct periods which are termed as three epidemics of the ROP. First ROP epidemic was observed in large preterm babies in mid-50s because of unrestricted use of oxygen. The second epidemic was seen in late 1960s and 70s in very preterm babies despite attempts at titration of oxygen. Severe ROP in the Western world right now is limited only to extremely low birth weight babies which are identified on routine screening. India and other middle-income countries are facing the third ROP epidemic, which is actually a combination of the first two epidemics. It's because in India, the larger institutes are providing very good neonatal care, where only extremely premature infants are showing ROP. But in towns and rural areas, even large and more mature infants are having ROP. It's projected that approximately 18,000 infants will go blind every year in India. So where are we now in India? In India, relatively even large and mature babies with birth weight more than 1500 grams and gestational age more than 34 weeks have been reported to develop severe ROP. So let's have a quick update on the levels of ROP in India. India has accounted for nearly 10% of the worldwide estimate of blindness and visual impairment due to ROP in 2010. In India, the incidence of ROP is between 38 to 51.9% in low birth weight infants. But very important thing is ROP is an avoidable cause of childhood blindness, so we should do screening and treatment properly on time. With this background, I'll move on to pathophysiology of the ROP. Usually, retinal vasculature begins to develop by 16 weeks of gestation and full retina matures near term at around 40 weeks. In ROP, when ROP forms, there are two phases which are observed. In phase 1, there is relative hyperoxia with downregulation of VEGF, which causes vasoconstriction and avascular peripheral retina. In second phase of the ROP, there is abnormal vascular growth because of increased VEGF secretions, which causes retinal and extraretinal neovascularization. Main risk factors for the ROP are prematurity and low birth weight. Other risk factors are high exposure to oxygen for prolonged period, apnea, sepsis, anemia, cardiac defects, multiple blood transfusions, and respiratory distress syndrome.
Sorry, Aditi, can you just move on a little faster, please? Maybe
yeah.
you can go to what's the update, what's new in ROP?
Yeah, so basically the new in ROP is ICROP3 classification. The ROP classification in 2005 has got modified. There are few new terminologies. Instead of aggressive posterior ROP, we call the ROP as AROP now. Because it has been seen that the ROP can extend to the posterior retina. The second thing is persistent avascular retina, PAR, which is a new terminology which is introduced by ICROP3 classification. When we give anti-VEGF injections, the ROP regresses in early phases, but late recurrences are very common because of this persistent avascular zone. So we should observe the babies till the retina matures completely so that the late recurrences can be avoided.
Thank you so much.
Yeah.
Thank you.